Eversold. Wonderful. Thank you, Ghana. My name is Monia Eversold. I'm the MHPSS International Focal Point and Project Manager at the Swiss Red Cross. And I'm co-leading this MHPSS network, research network, with the lovely Sarah Davidson, Head of Psychosocial and Mental Health at the British Red Cross, who's also here today with us. We are today's hosts, and we will trying to ensure that the webinar runs as smoothly as possible. For this reason, we also have Ghana and Sabina here, supporting us with the technicalities there from the PS Center, IFRC PS Center. Thanks so much for being there, hosting with us. Now, before we dive into this exciting and obviously relevant topic of today's webinar, I would like to briefly introduce the MHPSS Research Network, as not everyone here might be familiar with this network. So just a few information on what we're doing. This Red Cross and Red Crescent MHPSS Research Network was established in 2016 with the vision to provide effective humanitarian action through a strengthened evidence base in MHPSS. It is a space for collaboration and shared learning that brings together MHPSS researchers and practitioners affiliated somehow with the Red Cross and Red Crescent movement. The network is hosted by the IFRC Reference Center for Psychosocial Support and co-led by the British and the Swiss Red Cross. Now, what are we doing exactly? Now, the research network releases quarterly newsletters highlighting important developments in global mental health research, interesting events, or also funding opportunities. And then we host webinars like the one today that showcase best practice and highlight lessons learned by those conducting research or evaluating programming. And we also organize meetings where researchers and practitioners can meet, present their research or evaluations, and build new partnerships. So it's a lot about bridging this gap between research, between academia and the work in the field, the practice. Now, we are very much interested in connecting with national societies and other stakeholders who are interested in MHPSS research and would like to explore potential for research partnerships on mental health and psychosocial support in humanitarian settings. So if this is the case with you, if you're interested, please get in touch. So far concerning the MHPSS Research Network. And now, before I hand over to our lovely presenters for today's webinar, let me give you some technical information about this webinar. As I already mentioned in the beginning, after Victoria's and Rilana's input of about 30 minutes, there will be space for Q&A and for debate. So if you have any questions that come up during their presentation, please feel free to put them in the chat. Sarah Davidson will collect them and then bring them to the discussion at the end, so we make sure that nothing gets forgotten. And Sarah Davidson will also put links, interesting resources into the chat during this webinar, so make sure to keep an eye on the chat as well. And if you have interesting links, resources, feel free to also share them with the rest of us. Now, what are we talking about today? This webinar is dedicated to digital MHPSS, and why do we think this is an important topic? To go deeper. Now, as we all know, there's an enormous gap in human resources for mental health and psychosocial support at the global level. And this is especially true in situations of armed conflicts, natural disasters, or other emergencies where needs intensify and healthcare systems are overwhelmed. Especially in such contexts, there's a need for low threshold but efficient services that can reach more people at the most cost-effective way possible. And this is where digital formats of MHPSS actually come in. They provide a scalable and resource-efficient extension of traditional approaches of traditional care to mental health and psychosocial support. Today, up to today, we already have more than 300 studies pointing out that technology-empowered or internet and mobile-based interventions can be effective in addressing mental health and psychosocial needs, and in some cases can even be as effective as face-to-face interventions. Now, the Swiss Red Cross is exploring the potential of the smartphone as an essential widespread tool of connecting with vulnerable people groups, since 2021. And today we will hear about the Sui app, a guided self-help service with psychosocial support for refugees in Switzerland. This is the result of a very long participatory development process supported by academic research. And I'm very happy to have my two brilliant colleagues from the Swiss Red Cross here today. They will first present a general overview of the current state of research on digital MHPSS to give you an impression on what we're talking about. And then they will talk about the Swiss Red Cross's challenges and learnings with the development and implementation of such a scalable technology-empowered service. And finally, they will also give us some insights into the results of the randomized control trial, the RCT on the acceptance and effectiveness of the Sui app, which are actually still hot off the presses. Now, welcome, ladies. Let me quickly introduce you. Victoria Zöllner holds a master in psychology by training and works as a project manager at the Swiss Red Cross for the digital MHPSS and is in charge of this project with the Sui app with psychosocial support for refugees in Switzerland. And Rilana is a PhD student of psychology at the University of Bern. She's been leading the research project concerning the cultural adaptation and has been conducting actually also the RCT on the acceptance and effectiveness of this Sui app. Welcome, both of you. The stage is yours now.
Thank you very much, Monia, for this introduction. You already mentioned everything that we are going to talk about. So that's very good. A very warm welcome for us as well. We are very happy that so many people are interested in the topic of digital MHPSS for the most vulnerable, as it is digitalization becomes more and more relevant in all of our lives, and why not use it for the good, right? So as Monia mentioned, I'm a PhD student at the University of Bern, and I'm happy to present this webinar today together with Victoria. Victoria, just say a sentence so people can hear you.
Yes, so I'm project manager at Swiss Red Cross, as Monia just told, and I'm also very excited to have you in this webinar.
So to begin, we like to refer to the MHPSS pyramid, which a lot of you might know already. And it visually represents the optimal distribution that we would need for mental health support. Often we, as researchers in clinical psychology, focus on the very top of the pyramid, the specialized mental health care. It gets a bit more attention in research in academia and also in mental health generally. But of course, there's a broader context to all of the mental health for all of the levels of society. But we also will start from the top, specialized mental health care. We know that research shows that approximately 30% of the global population experiences at least one common mental disorder at some point of their lives. Yet only 30%, only half of these 30% receive any kind of mental health care. And the numbers, of course, go much lower as we integrate evidence-based mental health care, or if we look at lower income countries. So we have a really big gap already in the general population, and an even bigger gap when we look at economically less resourced countries. When we focus on mental health in refugees and asylum seekers, we see an increased vulnerability for mental disorders. Studies report a point prevalence, meaning who is suffering from a mental disorder right now, not in their lifetimes, but right now, of 30 to 40% for PTSD, as well as for depression, with a very high comorbidity rate between the two, and a rate of 11 to 40% for anxiety. So compared to the lifetime prevalence of the general population, this is markedly a higher number. And of course, we all know that there is a strong resilience also in refugees. We cannot ignore the fact that there is a high vulnerability and there are very high numbers in refugees for mental disorders. So given this well-known evidence for this high vulnerability among refugees, because this is very well documented, we could assume that the asylum systems have a very advanced system of caring for mental health for refugees. And we all could probably think of someone, a friend or a coworker or family who struggles with mental issues, and yet they are not seeking help because it's still for people who have grown up in their country, it's still a big hurdle to access to mental health care. And it gets even more difficult if you are a refugee, or if you are not speaking the same language, or if you did not grow up in the country you're living in. For refugees, there are a lot of cultural barriers. We have a lot of mental health stigma amongst the communities. And we observe also that there is a lack of mental health literacy, where they're not really aware of the status they are feeling in or they're in. And there is often also a mismatch between what refugees might think they need and what we can offer as a host country. And on top of that, once somebody is maybe ready to seek treatment, there are a lot of structural barriers. There is a financial strain, which might affect, for example, even the transportation costs you need to get to an appointment or to access a mental health care. And then the language, of course, is a very big issue. We have a lot of language barriers. We have not enough translators to cover these language barriers. And people are often also changing their apartments, their region they're living in. So this all affects the access to mental health. And on top of that, of course, the mental health care system is already very overwhelmed. And with refugees, it's the same, and even worse in a lot of cases, because of all these barriers that come on top of it. And specific to the refugee experience, we also can observe that through this dependency of authorities, there is a specific experience that gets even more difficult for refugees to access mental health, because it's often connected with trust issues to authorities. They have a lot of power over their lives, a lot of power over their immigration status, but not only immigration status, also about the times, for example, on which they can go out from the asylum center, which times they have to be at a certain doctor's appointment, or even how they can be brought forward from, for example, a counselor at the asylum center to the doctor in the end. So they have a lot of dependencies on the authorities, which makes it very hard for them to access mental health, even if they wanted to. So we have this very big gap, as we all know, and we try to tackle it with digital mental health, or at least approach it with digital mental health.
Yeah, I'm happy to share a few advantages of digital interventions with you. So Monja mentioned the effectiveness already at the beginning, but digital interventions are also accessible. So they can reach individuals who may have limited access to services, to traditional face-to-face therapies, for example. They may be in remote areas, or because of the barriers that Rilana mentioned before. So digital interventions can be used at any time, at any place. They can be scaled up more easily than traditional services in the mental health care system. They can also be affordable, have a low threshold, so you have immediate access to a service. You don't need to wait on a waiting list. They are normally for free, and yeah, they're also adaptable. So digital interventions can be translated and culturally adapted quite easily. So that's only few of the advantages. And yeah, of course, we also must talk about the challenges. We must also consider them. So even if digital tools do not require people to provide face-to-face services, there's many resources that are still needed to develop, but also to keep the interventions up to date. The quality is an issue. So lots of apps out there, they are not evidence-based or tested or evaluated. Data security, so ensuring the privacy and the security of the users of the most vulnerable is critical, but it's very challenging. And digital interventions, they are also not suitable for emergencies. So one last point, the lack of technology literacy, technical problems or difficulties to navigate digital tools can be very frustrating for the users. So this is also one of the challenges we must tackle.
So we know that digital interventions can be effective, and they have been proven to be effective to treat depression, for example, to treat anxiety, social phobia, and so on. And there are different formats of digital interventions. There is this very well-known medium of communication. The digitalization has helped us get through COVID. And this was also the case for psychotherapists who could continue their psychotherapies with their clients through video conferencing. It can be also used as an email exchange or a chat. And what we are researching on mostly at the University of Bern is interactive self-help therapy programs. They're mostly based on psychotherapy manuals from cognitive behavioral approaches and can be worked through by the client alone completely. But they can also be accompanied by a trained helper or by a therapist. So this company is usually called guidance because this guide or this therapist, this trained therapist or helper helps you guide through the self-help program. So we have self-guided programs or guided programs, and recently or more recently we have also blended programs where therapists meet the client and then leave them with the self-help program in between the appointments, so that there are so-called blended treatments, and we have evidence for all of them to be working. We also have quite a few digital interventions for refugees. It's not that advanced, but there are already some reviews I suggest for you to read through the reviews to find more information about what exists already and what is there in the market from digital mental health for refugees and asylum seekers. And I'm going just to quickly present two of them. The first one is Ilachnavsi. It's one of the oldest web-based programs that we know of, and it was developed in Germany. And it's also based on a therapy manual to treat PTSD, and it was culturally adapted to and translated to Arabic to treat war-traumatized refugees living in Iraq. And it was very successful, and it's still going on. They have shown moderate to large effect sizes in reducing symptoms of PTSD. And as I'm just going to summarize quickly what they've done, they had two times weekly structured writing activities over 5 weeks, and including self-confrontation, cognitive restructuring, and social support. And as you might already see, what the main issue there was, they had the main challenge that the people they were treating, or the participants in the study, had to be very literate. They had to be very well educated to be able to write such writing activities over such a long time and so many times per week. So that was the main struggle they had. And the step-by-step intervention developed by the WHO tried to tackle this issue a bit. It changed, of course, the focus during the development of the intervention, and they were finally trying to reduce depressive symptoms, which they also could achieve. And the step-by-step intervention was an application, so it was a bit more accessible for people who might not have a long education, but still have a phone. And the content of the step-by-step intervention, you still had to be able to read, but there were not that many writing exercises. And also, this step-by-step intervention was a guided intervention. The people got minimally guided by a weekly phone call, and they were also shown to be effective in reducing depressive symptoms. The biggest challenge they had for step-by-step was the adherence, as many people dropped out of the study and also did not finish the sessions that were meant to be finished throughout the experience. So we know that the fully self-guided digital programs, they are very accessible and can be effective, but we also know that guided digital programs usually are a bit more effective. There is evidence in the research that guided digital programs are a bit more effective, not only because there is guidance, but also because people usually interact a bit more with the program if there is any kind of guidance.
So Rilana has introduced the pyramid just at the beginning, and our MHPSS service, which I will introduce to you in a minute, focuses on the lower level. So we want to reach many people at an earlier stage with a low threshold service. We do not treat mental disorders such as depression, anxiety disorder, trauma, but address, for example, stress or sleeping problems, just topics that many people experience, many people can relate to. And the aim really is to normalize that and show that it is normal to have these feelings, to have these worries when you're in a situation that difficult when you arrive in a new country, and to show that there are simple ways, simple exercises that everybody can try. Yes, so in the next part, I will talk about this digital service that we have developed at the Swiss Red Cross. Please have a look inside. There's the German version and the Arabic version. Yeah, the Sui app is a peer-guided digital approach to people new to Switzerland, as Monja told you before. And after a detailed needs assessment and desk research, it was clear that the Sui app will not only contain psychological content, but it really needs to answer the questions that the refugees have when they come to Switzerland and when they integrate to Switzerland. So this is why the app contains 3 parts, and it's also the explanation for this Sui name. So it's all about self-help, support, and information. That's the 3 parts. So let's have a look at the content. For the yellow part, so this reflects the most important questions that the refugees have when they come to Switzerland, and they ask how they can find a flat, how they can get a permanent resident status, how to understand the healthcare system in Switzerland, how to find a job and get money. So the information part contains 9 topics, asylum relevant topics, and then there's also some emergency contacts. For the tier part, so the self-help part contains exercises and content that is evidence-based psychological interventions, and it includes, for example, mindfulness or breathing exercises, and information on stress and sleep and resources, for example. For the gray part, yeah, Rilana talked about interactive programs and mentioned the guided format. And that was also a great need for the target group to have the possibility to contact a real person. Therefore, we have implemented the chat where they can ask questions in their language and they are answered anonymously. And the users can get recommendations, for example, for their personal situation, but also on how to use the app better. And we call these persons peer companions. They are also called helpers, for example, in other programs, and they are trained by the Swiss Red Cross, but of course they do not replace professionals such as psychotherapists, for example, or social workers. And the app also contains many more than that content, lots of features, testimonials, videos, and glossary, for example, to understand Swiss-specific words better. Yeah, Rilana submitted her first paper and it's already available only as a preprint version so far, but this article really presents the participatory development process of the Sui app. And it also highlights the translation process, the cultural adaptation for an Arabic-speaking target group that we started with.
So we recently conducted the RCT, the randomized controlled trial around the Sui SRK app, and we have already finished with all the data. The article on these outcomes will be submitted within the coming months, but I will give you a short insight on what we have found. So we tested mainly our primary outcome to evaluate was a quality of life and what you can see here is the psychological domain, which goes from 4 to 20. And we have 3 groups. We have one group with this guided support, which is orange. We have one group without support, so a fully self-guided intervention, the Sui app as a self-guided intervention, which is the violet. And then we had a waitlist control group, which was the green group. And as you can see, the lines should go up through the users of the app to improve quality of life, but the lines remain rather straight. So we could not find any significant improvement through the app, which was not as we expected. So we now have to find out what caused this. So we did not find any significant effects on any of the outcomes we have tested. And we had, however, also had some insights on how people liked the intervention, the Sui app. So we conducted also interviews, we had qualitative analyses, and the satisfaction was quite high among the people that used the app. However, as in the step-by-step intervention that I presented before, we also had the main challenge that people did not use the app enough. We had 1/4 of the people who did not log in the app at all. So we are now, it's very important for us to discuss what might improve this interaction, this engagement with the app, because we listened to the target group, we listened to their needs, we adapted culturally sensitive, we tried our best to offer what was wished for, like exactly what they wished for. And so now we try to find out how to deliver it better, because we are still very convinced that the topics are correct, that the topics are the most wanted needs within the community. However, the interaction, maybe the delivery was not perfect so far, or not good so far. So we are trying to find out a bit more how to improve this so-called user experience and improve the digital support maybe a bit, and try to work also on the narrative on what the app entails, because often the interventions that were researched on in the past were very focused on a mental health disorder, but we were trying to cover a lot. So we need to work a little bit more on the narrative on what the Sui app actually is. So that's what we are trying to work on in the near future. And we are also trying or going to translate the app to other languages to see how target groups from other languages interact with the app.
Yeah, and the Sui app was published just recently, so it's not long online, currently in German and Arabic, and so far only in Switzerland. And it will also be made available for download in the EU in the near future. So please feel free to contact us, stay in contact if you want to be informed about that, so that you can have a look for yourself in your country. Yeah, there's a great demand for further language versions. We are therefore translating the app right now. So first of all, in Ukraine, English and French, we will publish this by the beginning of next year, and then also in Farsi, Dari, and Turkish by the end of next year. When starting the project, Swiss Red Cross has handed in a pledge to share the learnings, the innovation, the technology and everything with others. So in the meantime, the Swiss Red Cross led a working group to raise awareness for evidence-based digital MHPSS and provide guidelines then to implement digital MHPSS. And having the current research in mind, but also our experiences for the last few years, there are some recommendations on developing a new digital MHPSS tool we would like to share. And it's only a few of the learnings. There's many more that will be shared to really learn from existing resources. If you develop the content, to use existing technical resources, replicate and improve what is out there, and network-induced synergies before you start a new project. And talking about the technical part, I will talk about Direct shortly. It is the software that we used for Sui. It's the software to develop apps mainly with a focus on mental health. It is the result of many years of development at the Freie Universität Berlin, but also with several partners and international corporations such as the WHO. So Direct provides a content management system where you can edit the contents, for example, the text, illustrations, videos of your app, and an admin panel for users. So this is for study management, for example, and user management. The apps then you develop are available on iOS and Android, and the platform is really easy to manage and maintain. So there's no need to program if you want to publish an app with Direct. And the goal of this software, this platform, is to be a sustainable software and that it will be shared with the community. And we are very happy from our side to share our experiences with this tool and also about the amazing collaboration we had or have with the FU Berlin. So from the beginning on, it was the goal to share what we developed, as mentioned just at the beginning, that the digital intervention are scalable, are adaptable. We very, very much hope that Sui will be a starting point for new digital MHPSS services. And we have already spoken to a few national societies and experts about this, and are also open to discussing it with you and persons that are interested to work on what we build. So the framework, the content, especially the psychological content, illustrations can be used. Of course, the content Swiss specific is not will not be the right content. And of course, the platform that I just presented, the Direct tool, is also open to share. So all the documentation and the work of the working group, such as there's different sections that will be presented and published. on how to learn about digital MHPSS, dive deeper with lots of papers and guidance, a section on get inspired with good practices. For example, one is the Sui app, and then also a step-by-step guide on how to develop a digital MHPSS tool. All of this will be uploaded in October 2024, so not far. And all of this will be on the Peer Center website. So please feel free to contact any Monia, for example, any of the responsible, but also have a look when it is published on the Peer Center website. So this for now. Thank you very much for your interest, and we are very happy to answer your questions.
Thanks, Rilana and Victoria. These results are obviously not the ones we'd hoped for, but still we learned a lot from them. And I think it's also important to share results that are not the ones we wish for, because I think we can learn even more from them and from sharing the experiences that we made. We also already know, we have many hints actually why it didn't work the way we were hoping for. So that was really a really interesting process. Now I've seen there have been some questions already put in the chat. Sarah, can you maybe help us with the questions from the chat?
Of course. Yes, there are a few. The first one is, do you need to log in with personal data to use this app? Have you asked the user groups about the login? And if that is challenging, both with regard to data and the fear of being tracked or traced?
Yeah, of course, it was one very important topic we talked about in the user groups with the Arabic speaking group. And therefore, data privacy is one of the most important topics. You don't need to fill in your personal data to use this app, but there's two versions. So you can use it without a login, and you can also create an account. And this is the possibility for you to have this contact with a peer companion, to have this chat. For this feature, we need some information of you, so you need to have an account. But otherwise, it's really the minimum of data that is collected, and no personal data needed.
And of course, for the study, it was a bit different because we needed to collect data in order to see how it works out. And we needed quite a lot of information and a consent form, a paper signed consent form for the people to participate in the study. But afterwards, after this part, usually was not a big of concern. Like the consent, like this signature was the first or the most concerned we experienced within our participants. But later it was not a big issue. It was rather the login process that was a bit difficult, since you had to put in a code you received by an SMS. So I suppose, like, for the login procedure, this was the most difficult part, to actually technically have the ability to log in.
And also when we talked with the user group, it was also made clear that they have a great trust in the Swiss Red Cross. So also this is a very good sign that it's Swiss Red Cross who is producing and this product. So yeah, that was also very important.
Thank you both. Thank you. That question was from Christelle Winther from the Danish Red Cross. And we now have a question from our colleagues in the PS Centre. So it's actually 3 questions, so stand by on these. So the first is, did attitude barriers come up in the research, both the issue of mistrust to use technology due to data protection risks and mental health stigma? And how are referrals organised in the app?
So wait, you have to structure the question. So the first question was if there was any trust
attitude barriers. Yes.
Okay. So I know only, I mean, I have very limited information about people who didn't participate in the qualitative interviews, but from the qualitative interviews, we also contacted some of the people who were struggling with logging in, and there were almost no trust issues about data security mentioned, because they appeared before. They were already at the signature of the consent form. If they didn't want to participate in the app, they already did not sign the consent. And there, of course, there were some trust issues. People were really afraid to give the signature because they were thinking it might influence their asylum process. So yes, there were trust issues, but once we explained what the study was about and that everything was very confidential, and they agreed to participate, there were no trust issues mentioned anymore later. And the other questions?
Thank you, Ilana. So I think that answers the questions from the Federation colleagues, although there was a kind of supplementary at the end in terms of just lost it for a second. No, I think you've answered it. I'm going to move on to, but do come back to me if there are questions that you haven't, because I think, no, it was about referrals organised. How are referrals organised in the app?
So do you mean referrals to specialists, or what referrals is meant by it? So
I'm going to invite Ghana, if it was Ghana, to give us a supplementary on that one.
Yes, I meant the referrals to more specialized mental health services, if there is a need.
So we worked on a great database of lots of services in Switzerland, so on very different topics. And these services will be displayed in the app. So there's lots of this already, and then there's also the peers. So this peer companion in the chat also has access to all of this database of support services and can refer the users to a specific service, for example, in their canton, and really give them advice on how to use this service, for example, and which one could be the best for them.
Yeah, however, it's not a direct referral. It's only, like Victoria mentioned, it's only an advice what to do, because we cannot take the responsibility for that, because we don't see the people, we don't speak to the people. And that's what we try to make clear in the beginning also. It's not for emergencies and not to use in emergencies. So we cannot refer them directly to anyone, because obviously there is still the high mental health gap in the specialized mental health care, and there is not enough space if we say we can do that for everyone. That's just not true. We can try to support on a very low level, and that's what we're trying to communicate in the beginning of the app as well.
And there's also the possibility for them to recommend to use peer-to-peer services. For example, in person, there's a project in Switzerland where you can meet a person for 5 sessions, and then it's a real life person contact. And that's also one possibility where they can refer the people to try this program.
Thank you both. I now have a question from the ICRC, so we have all components represented in the questions. This is from Keenan, who is interested about the lack of significant impact around the quality of life for participants. He asks, apart from the satisfaction of users, were there any themes within your qualitative analysis indicating the potential factors of effectiveness?
So, yes, actually, it was. I mean, what was most interesting is that in the qualitative interviews, we all again asked, "What are your needs? What do you need in life? Where do you need support?" And they mentioned all the topics that we had in the application. So the needs were very clear. We really approached the needs that were mentioned. I just really think it's about the delivery, because people said, yeah, well, I just didn't use the app, and we don't know exactly how to improve it exactly, but we will try to do it in different ways. And there was also many people that wished for more interaction with a real person, which doesn't surprise any of us because we are social beings. And we try to engage people more using this peer support, because also in the study, this peer support sometimes did get lost, or they didn't see that there was support, or they believed that it was a robot or something like that. So we try to improve this interaction, because that's what they wish for, and that's where we see potential to improve the application again, and to improve also the engagement with the app. But the needs were very much covered by what we had inside in the chapters of the app.
Thank you, Ilana. And Keenan has a follow-up question, which is another potential aspect is for whom the app might work best. So a randomized control trial design may block the contextual differences amongst participants. Does your qualitative analysis direct to who might benefit best from the intervention?
So thank you for this. Is a very important question, and not yet. We had done some descriptive analysis and the quantitative data of the subgroups that might have been best, but we didn't find any patterns yet, or not very clear patterns, some tendencies, but not really good to go. So we will try to find that out a bit more with the qualitative data, but we don't have too much insight in that yet to be able to communicate anything.
Thank you both. There is just an issue in terms of accessing the preprint, but as you said, when you have the published article, that will appear both, I think, on the digital platform that I put in the chat, and hopefully also on the research network. We will do a link through, and I'll put that again in the chat. I'm going to pass back to Monia with thanks.
You can feel very free to open your mics also if there's still more questions, further questions, or topics that you would like to have deepened by Rilana and or Victoria. The one of the questions that was addressed directly was also concerning the cultural adaptation. You said you worked in a very participatory way with refugees, with Arabic-speaking refugees. Can you maybe just mention one or two more details on how you went about that? I hope I summarized the question correctly.
Yes, of course. So we worked in this participatory approach from the beginning on. So right at the beginning of this project, we started to form a user advisory board, a user group with Arabic-speaking people, having diversity in mind. So people that live for a long time in Switzerland and just arrived in Switzerland, for example, female and male, and also different resident status. And then there were different development phases, and first how to define the topics, for example. We asked them what are the questions that they really need to, what answers they really need to have. And then we worked on each of these topics that we have shown to you together with the group. So there was the text, and we really revised the text with them. They made the decisions on the text. They also made the decisions on the illustrations. So we showed them first, and then we adapted it. So it was always the cycle of bring something to the group and then work on it and really let them decide and adapt it and bring it to them again. So that was always the cycle on how we develop the content, the videos, for example. So that's also one possibility of a participatory approach for them, to let them speak in these testimonial videos where they can show their perspective and their hopes and what helped them and what was difficult for them. So that's only two aspects of this participatory work we did.
And how long did it take for this whole process of development of the app before it was being published?
I think it took us around about 2 years with the Arabic-speaking Arabic version. Not Rilana.
Yeah, and of course there was some policy making before these 2 years where we could actually work. So we had to set up knowledge in our in the Swiss Red Cross that we can conduct all of this. And yeah, I would say around 2 years until the study could be started, and a lot of work before that has been done. And of course, we will continue. And yeah, you have to be aware of, if you start a digital intervention, you have to be aware that it's continuous. It's not a print. You have to be aware it will continue on and on and on, because digital interventions, it's just an ongoing issue. And yeah, also Microsoft is continuing all the time.
And also, again, with each language, of course, we are having a group with Ukrainian-speaking people right now for this translation. So it will be the same for every new language, that the target group will be involved and will be part of this process.
Sarah.
Thank you both. Just to applaud your stamina as well in staying with this long process. It's very impressive. I have a supplementary question from Christelle from the Danish Red Cross, who asks if you could just say a little bit more about how the information is presented on the app, particularly about how are sleep and stress issues presented. So is the information mostly text-based, or are there also videos and exercises? And just a final supplementary on that is, what's the length of the content? So how long possibly does it take to go through it all? Thank you.
Do you want to answer, Victoria, or Sida?
You can go first and I will add.
Okay, so it is mostly text-based, but for every topic we inserted also a testimonial from another person, Arabic-speaking person, that explains their side of it and how they experienced stress, for example, or sleeping problems or pain. And but mostly it is text-based. But we also have audio exercises. We have quite a lot of audio exercises, and we have some interactive exercises where you can, for example, make a list, or just read an exercise and try to do it yourself. And so it's a bit of a mix of features of the app. And it probably, for example, the stress chapter probably takes maybe 20 minutes to go through, because it's really just information. And then we have audio exercises that go for between 3 and 6 minutes per exercise, and you don't have to do all of them. And for every chapter, it takes around, I would guess, around 30 minutes to go through, if you don't do everything, if you just do what interests you. And you don't always have to do all of the exercises. You can choose which one is fine for you at the moment.
And having the literacy in mind, there's also the possibility to listen to all the content. So of course it's lots of text. For the psychological content it's less text, but then the information part, it's really heavy and lots of information. So we provide audios. So on each slide, on each page, you can listen to the content that is written there, and you don't need to read it yourself if you want to have that. That's also available in every language.
Wonderful. Thank you. So, being mindful of the time, we're coming to close this webinar. Thank you so much. Maybe I can just summarize the most important points, the take-home messages that we've heard today. So digital mental health interventions have proven to be effective for providing specialized treatment for various mental health conditions that we know, but, and this is what we experienced also at the Swiss Red Cross, to be effective, they need to be used. And adherence is obviously one of the biggest challenges, as we heard, with digital interventions. And this challenge really needs to be addressed. And it can only be overcome, I think, if we really get very close to the needs of the potential users. And other common challenges that you mentioned were technological barriers like access to devices or internet. And I think here it is very important that we are careful not to create new inequalities with our services and that we exclude people. So this is one thing we really need to be very mindful of. And then there's also cultural differences, different narratives about mental health that need to be considered, that needs cultural adaptation, contextualization. And then there's also the varying levels of digital literacy that must be taken into account, and that really has a big influence and impact also on the content that you can, or the exercises that you can use with the different target groups. So I think the most important conclusion that we can draw is that digital mental health interventions really required collaboration and co-development with different stakeholders to ensure that the intervention is really meets the needs of the target groups, that it's acceptable, and that it's also very relevant to the diverse needs of the refugee communities. And there's also an issue with sustainability when it comes to digital interventions that is really important. You mentioned that a bit, that we did a lot of preparatory work in the Swiss Red Cross. It's not only about the needs assessment that we made beforehand, before starting, to make sure that the digital solution is the best way to go forward. It's only a means, it's not the end. And that's one thing. The needs assessment, of course, is very important, but it's also important to include the relevant stakeholders right from the beginning, to make sure that this intervention is embedded into an existing healthcare system, that referrals are possible, that we have in Switzerland, we are very lucky to have the cooperation system with different local Red Cross branches that offer psychosocial support, where we can send the people to where they're cared for, taken care of. So the referral is a very important topic also, which really needs to have the stakeholders on board from the beginning. And that makes us the stepped care approach also possible. I think that's the most important point. Now I just want to say thank you to Victoria and Rilana for presenting your insights, sharing your learnings with us, and to all of the participants here for these fruitful and interesting discussions. And last but not least, and then we can stop just on time, we would like to invite you to our next webinar. It's the last in the series for this year. It's going to be held on Tuesday, the 3rd December. The time is yet to be defined. And it's going to talk about the integration of mental health and psychosocial support in the Red Cross and Red Crescent movement across different sectors. So please join. You'll definitely get more information on that webinar at a later moment. And if you want to stay updated, please subscribe to the newsletter of this MHPSS Research Network. Sarah will put the link to our webpage so that you can find us. You can also find the recordings of this webinar and other interesting resources there. And as we mentioned, we also have a digital MHPSS focus area that will soon be posted or published on the PS Center's webpage. By mid-October, you will find all the resources that we talked about here today on this focus area. So now I wish you a very nice rest of the day. Thanks for joining. Thanks for being with us, and hoping to see you soon in the next webinar.
Thank you so much.
Thank you very much.
Thank you.
Thank you. Have a nice day.
Bye.
Thanks so much.
You. Bye bye.